Good morning, everyone. We're so happy to have y'all joining us back for our childbirth education classes. My name is Bonnie Bearden. I am the clinical director of the NICU as well as the Women's Care Center here at CHRISTUS Good Shepherd, which is our postpartum mother-baby unit. So with me this morning, I have one of our neonatologists, Dr. Chen, and he is going to talk to you a little bit about when a neonatologist may be asked to join your baby's care. Dr. Chen has been at CHRISTUS Good Shepherd for about 11 years now.
Something like that.
Our other neonatologist is Dr. Chris, and he is actually our medical director. He was one of our founding neonatologists for the department, and he'll be joining us in just a few moments. So I'm going to go ahead and let Dr. Chen start.
So good morning. I think I'm just going to try a brief overview of what I do and which babies that I take care of. Typically, for the healthy babies, the pediatrician does all the work. And so they only ask the neonatologist to step in when there's something unusual or something that's the baby's acting sicker than normal. Approximately 10% of all deliveries come to the NICU. That's all full-term babies. Premature babies that are 34 weeks and less, they all come to the NICU. So we do have plenty of potential issues of, is your baby going to get admitted to the NICU? It's still only a potential risk. And hopefully with good prenatal care, the chances are lower. But the most common reasons why, besides prematurity, the most common reasons why babies get admitted to the NICU is because they're having trouble breathing or they have low blood sugars. So those are the two most common. The breathing issue, as normal deliveries occur, the lungs are typically filled with fluid in the beginning. And for a normal delivery to occur, that fluid has to get pushed out and reabsorbed. If it doesn't, babies have trouble breathing. And so that's the most common. It's a very short-term problem from the breathing standpoint. It usually goes away within 24 or 48 hours, and the hospitalization in the NICU is very short. The same thing goes with blood sugars, that maintaining a baby's blood sugar is very important, and after they're born, they don't get the sugar that the mom would typically give them, and so they're at risk for having low blood sugars. Those problems, again, are very short-lived, and typically in the first 24 to 48 hours, maybe 72 hours, we're able to stabilize the blood sugars, and they can go back out to mother's room. We want the bonding process to occur as quickly as possible. And so we don't want to keep the babies in the NICU any longer than we have to. And so when they're ready to go out, we want them to be with mom so that the normal nurturing and bonding can occur. There are many, many other reasons why babies come to the NICU. Most of them are a little too complicated to just talk in general, but the three big issues are prematurity, breathing issues, and blood sugar issues. The NICU takes care of all babies that are 23 weeks and above. Our unit does all the, what I would call basic NICU procedures. We have special ventilators. We have the special equipment that all the babies that are sick that they need. And so I feel like we do a very good job in taking care of the needs so that the babies do not have to be transferred to a bigger facility. Actually, Dr. Chris has just walked in.
Step out and let Dr. Chris join us.
So Dr. Chris is the medical director of the NICU. He started the NICU in like 2004, I believe. And so I was just talking about potential admissions.
Okay.
Yeah.
So how you're doing? Is it ladies, any gentlemen there?
I don't see any gentlemen.
All ladies?
Yeah, they're
Okay.
unmuted right now.
All right, so I'm Dr. Chris, and I have had Dr. Chen. We worked together here for almost 15 years.
Since 2007.
7, and you're gonna have a wonderful experience having a baby here. We have the first NICU in East Texas. When we started the NICU here, there was none between, I think the closest was either Dallas or Shreveport. So we've been doing this for a long time. We pray that you all have normal full-term delivery, but if there's ever a problem, we have a wonderful team here, neonatologists, nurses that have worked in the NICU for a very long time, regular nursery nurses and midwives, and we'll all work as a team for you to have a wonderful experience. Having a newborn baby is a blessing, and we're here to assist you all. The only thing we don't do here is surgery. So if a baby ever needs surgery, may need to be transferred to a higher level of care. But most of the other problems, respiratory issues, premature babies may have, babies, need to have IV fluid, need to be monitored closely in intensive care unit. We're here to take care of that.
So if a baby has to enter the NICU and you become involved, either one of you become involved in that patient's care, how do you go about evaluating the baby and then communicating with the parents about what the plan of care will be?
If we anticipate a problem, if the midwife tells us, or the OB informs us before time that we may be having a premature baby, or we may be having, maybe a mom has diabetes, insulin, usually we'll have enough time to talk to you when you come into labor. And the L&D nurses are wonderful at doing that. They will inform us, either myself or Dr. Chen or one of our nurse practitioners will come in and answer your questions and kind of take you through what your experience is going to be like. If a baby needs to be in the NICU, what the rules and regulations are. We try as much as possible to still let you bond with your baby, because that is very important. Again, we do our best to treat the baby that is in the NICU, and as soon as they are able to leave the NICU, we'll transfer them to be with you in your postpartum room. And usually just getting to know you before the delivery, if you have any questions, if you have any concerns, that would be the best time for us to answer them. Where because of COVID-19, we have stricter rules now, because we really we want to protect our babies, especially our premature babies in the NICU. So we have, kind of cocktailed our visiting rules and regulations and who can come into the NICU. I think Ms. Natasha, Ms. Bonnie, they probably they know more about those rules. I think now we're just restricted to parents and only one person at a time. We used to allow grandparents to come in, and basically we used to allow older siblings that are more than, I believe, 12 or 14 years. But now it's just, dad and mom, and one person at a time. And we follow our regulations. You wash and scrub your hands as soon as you get into the NICU, and we require you wear a mask while in the NICU for the safety of all, babies in the NICU and also for all our staff.
So I think if it's a planned difficult delivery and we already know that there's going to be problems with the baby, then we will most likely be in the delivery room when the baby's born. Some things are kind of unavoidable or unexpected, and so for normal babies, we're not in attendance because, one, we're not the pediatrician, we're not the doctor of record, but for babies that we know that are going to come out sick or potentially sick, we want to be there at the delivery. And so we have a whole delivery team that's made up of 4 or 5 additional people so that we can take care of your baby in the beginning, because the first several minutes are the most important. We want the baby to get kick-started in the right direction so that we have the best chances of being healthy. We want to take care of the baby first. So sometimes we don't always have time to fill you in with all the information in the beginning because we're stabilizing the baby. And then we'll come back into your room and kind of tell you what's happened, tell you what the plan is. Sometimes when the babies are very sick, we get you into the NICU quickly because things are happening so rapidly that we want you to be involved in and know what's going on. But typically, for most babies that are admitted, we just need a little time for them to transition, and so we will stabilize them, then we'll come back and talk to you about what's happened.
And again, we don't want you to be scared because you hear all of this. We're talking about problems that most likely will not happen. About 95% of deliveries are, normal. The baby comes out, the baby screams, and we're all excited, high five, and then we'll clean the baby up, and baby's handed over to you right there while you're still on the delivery table. But what we do, because we know there's always going to be, a few babies that may need some extra help. So we are always ready 24 hours. The NICU is maybe about 50 steps from L&D. And we have a nurse practitioner that is in-house 24 hours. And the neonatologist, when we are called, will be here in about 15 minutes. So we just want you to have that, rest of mind that if there is a problem, that we have the team that will take care of your baby.
So in follow-up with the babies, how often do y'all see the babies on a daily basis and interact with the parents? And then how do you collaborate with their chosen pediatrician?
So what we do, we have a nurse practitioner in-house 24 hours. We round in the morning, and then in the evening again, we'll do another round. And we speak to the parents at least once a day. But when you come to the NICU, we've already had our rounds, and every member of the team, the nurses, the respiratory therapists, the neonatologists, they know the plan we have for the day. So, the bedside nurse who is watching the baby, they're on the monitor, they're watching their heart rate, their respiratory rate, their oxygen, and they can tell you most of what we're doing, the plan. But if you really need to talk to us, the neonatologists, anytime we're available, we can FaceTime, we can talk to you on the phone, we can have a conference while you're in the NICU. And also if the baby's in NICU, if you tell us who the pediatrician is, we do communicate with them, let them know how your baby's doing. And also we do send the discharge summary to them when your baby's ready to go home.
Yeah, most pediatricians, they want to know what's going on if they have a relationship already with the family, but they don't deal with the day-to-day process of the babies that are in the NICU. So we end up taking care of all the problems during that time. And we're happy to keep the pediatrician involved if they're aware. Yeah.
Are there any questions?
Ladies, do you have any questions for Dr. Chris or Dr. Chen? Okay. We don't have any questions in the chat box. It doesn't look like we have questions at this moment. Thank you, Dr. Chris. Thank you, Dr. Chen. And so we'll start on our next section of the course for today.
All right.
Thank you.
Thank you.
Thank you.
Good morning, ladies. I'm Selena, midwife. This is Midwife Dion.
Morning.
We're actually mother and daughter. So we have a little talk that we want to do, and it's called Uterus Talks. We're going to talk we're going to give you some facts about your uterus. Number one, some people think the uterus is the drama queen of the body because this uterus does so many things. This uterus leaks every month. This uterus cramps sometimes. But this uterus is very amazing and can protect your body in a lot of ways and hold all your organs together. So we're just going to share some facts with you. I'll let Dion share one.
So on the normal female, the uterus can be about the size of a pear. By the end of pregnancy, it can be about the size of a watermelon, which is pretty amazing.
So I want to share with you that the uterus is the only organ from both male or female that can actually grow another organ. It can grow placenta and nourish your baby.
It's pretty cool. The other thing is that women can be born with no uterus at all, and their bodies will still go through the hormonal changes of puberty, or you can be born with actually 2 uteruses, which is pretty cool too.
And 2 uteruses might be kind of, they might not get along when it comes to birth. So that's something that your doctor would have to talk to you about and make plans accordingly. So the other thing about a uterus is it is 24-hour womb service. Your turn.
Some uteruses are actually shaped like a heart, and they're called bicornate uteruses. And those are pretty special when we're pregnant. You have to watch those a little bit closer, but it's pretty cool that it has that shape.
The uterus actually will work to stabilize all the other organs in the pelvic area. So if when your uterus is not pregnant, it actually is about the size of your palm, or like we said earlier, about the size of a pear. And there's ligaments that attach to it, and they hold your bladder. Everything holds your bladder in place. The other organs in the body, the intestines, are all situated around the uterus, and so the uterus is really a stabilizing force within the pelvic area.
And did you know that last year there was actually a successful uterine transplant where a term baby was born for a woman who couldn't have a baby on her own? It's pretty fascinating.
So one of the interesting facts that isn't true is that the ancient Greeks and ancient Egyptians had a term that they used called wandering womb. They believed that everything that happened in a female body, sore throat, cough, headache, it was all because of a wandering womb. They believed the womb could go to different parts of the body and do different crazy things. They also really thought that that's why women are women and act crazy.
I'm trying to find, I think. Some uteruses, when we have you come into the office, women will say they have a tilted uterus. It's actually called a retroverted uterus, but tilted seems to be more a common phrase that's used. And it's just something that you're born with. It's not anything that's wrong. There's things that can cause it, like scar tissue caused by endometriosis or infection, but really it shouldn't affect whether you have a baby or if you're fertile or anything like that. Sometimes it can be a little bit harder to get a pap on you, and we may say, oh, your uterus is tilted. But again, it's nothing that you should worry about.
So when you're pregnant, one of the things that we do during a prenatal visit is measure the uterus. We'll always take out a tape measure and we measure in centimeters. And the reason why we do that is because your uterus should measure between 2 centimeters above or 2 centimeters below your week's gestation. That helps us to know if your baby is growing properly. And it's a really important measurement for us. It's not something that we take lightly, although we'll laugh and joke while we're doing it. We're really paying attention to how your baby's growing.
The other thing that we do during your visit is we may mash on your stomach and your uterus to find the position of the baby. These are called Leopolds Maneuvers. So when you come into your visit, as you become in the 20 plus weeks, we really begin to press on your abdomen, and we will often tell you the back of your baby is here and your head is either here or here. And then we'll show you where we get the heartbeat based on that. So those are very important maneuvers, and we feel all of those things by feeling of your uterus.
So after your baby comes, we're still pressing on your uterus and it doesn't feel too good. Most people will grab our arm and say, do you have to do that? The reason why we do that is that once the baby's born, your uterus is kind of boggy because it's had a really fast decrease in size. And we want that uterus to clamp down and to decrease the amount of bleeding that you have right after you have a baby. We're trying to avoid a postpartum hemorrhage. And so we will rub your uterus to make sure that it's nice and firm and in the middle of your pelvic area, and they will teach you how to do that so that you can check that for yourself. And if you're having a little bit too much bleeding, you can check to make sure that your uterus is nice and firm.
A few other things about the uterus is when you're still pregnant, you may have, if your baby is in a position that's undesirable for labor, the uterus is very smart and it will contract around to push the baby into a position that's more desirable. And then postpartum, after you deliver and the fundal massage that she explained happens, your uterus will sort of have a period over a period from delivery all the way possibly up until 6 weeks. And the bleeding will typically start out bright red and then go to a darker red and then turn to a brownish or yellow over time. And if when you get home, you start doing too much around the house, that will actually increase and tell you that you're doing too much. So it's pretty awesome in the fact that it tells you to slow down just a little bit.
So probably the last thing that I want to say about the uterus is that uterine cancer is the 4th leading cause of cancer in women. It's also the 7th leading cause of death in women. So it is very important to try to maintain your health in every aspect to avoid having any type of cancer. The most common kind of uterine cancer involves the endometrial lining or the endometrial cells of the uterus. And if you are obese, you have a 2 to 4 times more likely chance of having uterine cancer because the fat cells in the endometrium or the endometrial lining actually hold all this extra estrogen, and that estrogen can be a precursor for uterine cancer. So like I said, it's really important to maintain your health in every way and to establish for yourself a good healthy weight. Anyway, we appreciate you tuning in today. If you have any questions about the uterus, throw them at us right now.
Hello. I'm Lisette. I'm a first-time mom, and I have a subchronic hematoma. And so I was wondering, if it lasts up until delivery, is there anything that I should know about?
Subchorionic hematoma is an area behind the placenta that hasn't attached well to the uterus yet. It's very, very uncommon that they don't resolve themselves. So it's important for you to practice different safety precautions. Like number 1, don't be lifting anything heavy at all, nothing over about 20, 25 pounds. Make sure that you're not doing any heavy exercise and watch for any episodes of bleeding. If you're having bleeding, let your provider know. But what happens over the course of a pregnancy is that your body will your uterus will actually be able to adhere to that placenta and stop that bleeding. And there'll be a clot there because that bleeding will stop and it will clot, and then it will slowly just dissolve and resolve itself. So you probably should not. It's very, very rare that you would have that problem left at the time of labor and delivery.
Okay, thank you.
Uh-huh. Does anybody else have a question? Okay, well, we appreciate you coming. We'll have a class next week at the same time, and we hope you enjoy the rest of your day. And then if you need to speak to a provider, or if you don't have a provider, please feel free to call our clinic at 903-315-5733. We're here for you, and we can also do same-day appointments. Thank you.
Ladies, I'd also like to let you know that if you were having trouble looking at our previous sessions, please check out the link that we provided for you in the chat section.